Hey everyone, it's Becker. Today we're going to have a short presentation on benzodiazepines. With that, the goal of this presentation is kind of multifold. First, we're going to review the mechanism of action of benzos. Then we're going to review the specific benzos we carry, which are going to be Midazolam and Lorazepam. Then finally, we're going to discuss some of the decision-making processes of the use of one of these over the other. So how is it that benzos work? So benzos are known to enhance the inhibitory transmitter gamma-aminobutyric acid, which is known as GABA. So GABA acts to inhibit neural activity because of the extent to which it decreases the action potential of a neuron. By expanding this action potential curve, GABA slows the rate at which cells of the central nervous system fire. So one of the ways I kind of think about this is just like the action potential of cardiac cells that we've all kind of learned about in cardiology. So just like we have medications such as amiodarone, which are going to extend that action potential, thus slowing down the heart rate. When benzos act on gamma, we're doing that same thing where we're extending that action potential, and it's taking longer for those neurons to fire and then repolarize after firing. So all that is going to cause a number of different effects, such as sedation, hypnosis, decreased anxiety, amnesia, as well as muscle relaxation. Like with any other CNS depressant, ventilatory depression is a common side effect. Furthermore, one can expect a reduction in the arterial blood pressure. Because of this decreased peripheral vascular resistance, you'll usually see the patient's heart rate increase in order to maintain their cardiac output. These two facts will kind of repeatedly come up throughout this video. And just remember, as with any other controlled medications we carry, care should always be spent on the hemodynamic stability of the patient, and then as well as the patient's ability to ventilate before, during, and after administration. When looking at the specific benzos that we carry, Midazolam and Lorazepam, their uses can be generally divided into two main categories: seizure cessation and sedation. So with that, we'll do a quick kind of review of the dosages of each. So for Midazolam, if given for seizures, we're generally going to go 2.5 to 5 milligrams IV, intramuscular, intranasal, or through an IO. Chemical restraint is going to be generally dosed 1 to 5 milligrams IV or 2.5 to 5 intramuscularly. For giving sedation for cardioversion or pacing, should be a dose of 2.5 milligrams. And for pre-sedation for RSI, we're going to be looking at 0.1 to 0.2 milligrams per kilogram. Moving over to Lorazepam, generally this is going to be a 1 to 2 milligram dose, either IV, IO, or intramuscularly, with a max of 4. One thing I didn't notice is don't forget the max of Midazolam is going to be 10 milligrams. Moving on to pediatric doses, for Midazolam, we're looking at 0.5 to 0.2 milligrams IV or IM, with a max of 5 if given for seizures. Chemical restraint is going to be 0.1 milligrams per kilogram, and that same 0.1 mg per kg is going to go for chemical restraint, cardioversion / pacing, and for sedation for RSI. Moving over to Lorazepam, pediatric dose for that is going to be 0.05 to 0.1 milligrams per kilogram for a dose no greater than 2 milligrams with a cumulative max dose of 4 milligrams. With respect to the contraindications of each of these, I'll let you kind of review some of the specifics. However, generally speaking, those who are hemodynamically unstable, already comatose, or those who have any respiratory insufficiency should not be receiving benzos. And finally, kind of branching off of that same kind of hemodynamic stability and respiratory insufficiency, keep in mind, obviously, with any controlled substances we give to a patient, it comes with a great responsibility to you as a provider. So just remember that these patients need to have a close eye kept on them. They need to be continuously monitored via 4-lead, CAPNO, and then kind of continually reassessed for respiratory effort and effectiveness. So now specifically looking at benzo use in treatment of seizures, The choice of benzos really is a decision that should be based off of IV access available to you at the time. In the case of an actively seizing patient with no IV access, non-IV administration, whether that's intramuscular or intranasal administration of benzos, is generally going to be more pragmatic to an IV administration. Though IV administration will have a faster onset of action, it's going to be markedly more difficult to establish if tried on an actively seizing patient. In a recent study which compared IM Midazolam versus IV Lorazepam for the pre-hospital treatment of seizures, it showed that in the group receiving IV Lorazepam, 28% of the patients didn't receive any medication because IV access couldn't be established. So initially that might not sound like a terribly high number. However, this was the second leading cause in the study for people not receiving medication. It's, in this case, second only to the seizure stopping on their own. Furthermore, kind of unsurprisingly, this study found that IM Midazolam is just as capable at stopping seizure activity as IV Lorazepam. Non-intravenous Midazolam also shines because of its faster onset of action. When compared to IM Lorazepam, which has an onset time of 15 to 30 minutes, IM Midazolam will have an onset time markedly faster at about 10 to 15 minutes. This time of onset is even faster when administered intranasally with an onset time of 3 to 5 minutes. IM administration also excels insofar as it doesn't require the use of a needle, which again can be a lot more pragmatic in the case of someone actively seizing and lessening the chances of an accidental stick or improper IM administration. So in the situation where IV access is not available, midazolam really should be your go-to with respect to controlling seizures. But what if IV access is available? Which benzo is preferred then? I tried to find studies comparing midazolam and lorazepam when they were both administered IV, but was unable to find any. Therefore, I would suggest that the decision on which of these to use should be based off the desired duration of effects. IV midazolam has a duration approaching 60 minutes, while IV lorazepam approaches 120 minutes. If you find yourself in a situation where controlling multiple frequent seizures or someone in status is required, the longer duration of lorazepam may be value added in controlling the patient, whereas if you're controlling what you think might be potentially a one-off seizure, the short duration of midazolam may be more value added in that case. The second large pool that comes up in the indications for our benzos is sedation. Now, sedation is a topic that is both wide and deep, and really should be thought of as a spectrum. Our protocols list 4 reasons for sedation, which includes to minimize anxiety, awareness, recall, or oxygen demand, synchronicity with mechanical ventilations, in order for the patient to better tolerate procedures, and to protect the patient and caregivers. Like I said, this is a wide-ranging spectrum of reasons for sedation, which range from relatively straightforward cases of administering benzos for anxiety all the way to controlling violent patients. So the decision-making process on which med to administer, at what dose, and what route are going to be situationally dependent, but will generally kind of follow a handful of decision-making processes. Just like in seizure cessation, what access availability you have is going to drive your initial decision-making process. So your ability to gain IV access on a patient needing sedation who is in excited delirium is going to be markedly less than a patient who needs some mild sedation in order to tolerate a procedure. Along with the question of access is also the question of the time-sensitive nature for the need for sedation. If the patient requires sedation immediately and you do not have any IV access, then just as with controlling seizures, the use of non-IV midazolam will probably be preferred to either IM, lorazepam, or starting an IV. Second, as echoed before, what's the desired duration of effect you'd like to achieve? In the case of something like sedating a patient prior to cardioversion or sedating a patient who cannot comply with the short-term procedure, lorazepam, because of its long-term duration, probably won't be as preferred to as midazolam. And vice versa, for more long-term sedation, for example, in order to tolerate continuous pacing, the long-term duration of lorazepam may be preferable. Lastly, I would consider if ketamine would be a more beneficial agent of chemical restraint opposed to a benzo. IV and IM ketamine both have an onset time quicker than either of the benzos we carry and provides a different safety profile than benzos. Remember that ketamine has a associated catecholamine release with its administration, which is going to increase the cardiac output with a combination of increased heart rate and increased vascular resistance. Now remember that compared to benzos, which we talked about earlier, which is generally going to decrease our peripheral vascular resistance, and our bodies are going to have to work harder to increase the heart rate in order to keep up our cardiac output. So one area where ketamine does appear to shine when compared to benzos is in the control of the actively combative patient. Though it was a relatively small retrospective study, you can see the results of a recent study that compared the effectiveness of benzos and ketamine in the controlling of the actively violent patient. You can see the agitation scores, in this case measured by the Richmond Agitation Sedation Scale, in the second column from the left. All the groups generally started in the same place, which is going to be a score of 4+, which describes the patient as being overly combative or violent and being in immediate danger to themselves or staff. Following the chart to the right, as it measures the reassessment of the RASS score, ketamine was superior to both midazolam and lorazepam at the 5, 10, and 15-minute marks, and the overall time to control the patient was markedly less in the ketamine group opposed to the benzo group. At the same time, while ketamine appears to work exceedingly well in the actively combative or severely agitated patients, it is pretty limited if you're looking for anything less than total disassociation. Remember, ketamine can cause vivid hallucinations and disturbing nightmares. Partially disassociating a patient can be a profoundly disturbing event for the patient, and could cause the overall control and management of that patient to be tenfold more difficult. In a situation of partial disassociation, just think of all the same vivid hallucinations or disturbing nightmares that a patient would typically experience while totally disassociated are now occurring in a state where they're still conscious and able to kind of act out in their environment. Anecdotally, I've had at least one patient who I've partially disassociated, and this patient was off a relatively small dose of ketamine. If memory serves, it was only about 30 milligrams, I believe, and it made the interaction markedly more challenging. And in many times, a situation where someone's partially disassociated, now your only option at that point is to totally disassociate this person. Otherwise, like I said, the management is going to be tenfold more difficult. So the use of ketamine really should remain aimed at the ends of the dosing spectrum, which is to say low doses for pain management and high doses aimed at full disassociation. With that said, any mild to moderate sedation that's required is really best served being achieved through benzos. As we wrap this up, I just want to reiterate that the decision-making process for the use of and selection of the benzos we carry is multifactorial. Midazolam shines in situations where lorazepam doesn't, and vice versa. Our toolbox has a number of tools in it, and I hope this has kind of helped in kind of differentiating some situations where one of these tools may be superior to the other. If anyone has any questions, comments, or clarifications, please reach out to me or your captain. It's my goal to send the links to some of these studies I referenced, as well as a short podcast speaking on the use of ketamine, specifically where they speak about partial disassociation and kind of the challenges of managing that patient. Along with those references, we'll also send out a short exam. So I'm not sure right now at the time of the recording when it's going to be due, but just check the email and it should be in there. Please finish the exam, scan it, send it into Stefan, so that way we can get CEs for the short presentation today. And other than that, again, I hope this was helpful, and if you have any questions, please reach out. Thank you.